Can I welcome members, invited guests and the public, both here and those watching on the webcast, to today's meeting of the Health Committee. Our main topic of discussion is the London Ambulance Service, and we encourage anyone taking part in the discussion on social media to use the hashtags #AssemblyHealth and #FutureAmbulance. First, a few items of formal business to go through. I note there are no apologies for absence, so we have a full turnout. Thank you very much to all the members. Can I ask the members to note the list of offices set out in item number 2 of the agenda? We'll also ask members if they have any interest to declare. Yeah? Yep. Thank you. Can we note the minutes of the meeting on the 17th of July 2018? Noted. Thank you. Can we note the completed and outstanding actions from the previous meetings? Noted. Can we note the recent action taken by me as chair under delegated authority, namely to agree the response to the health inequality strategy, draft implementation plan and indicators, and note the response as attached in Appendix 2 of the report? Okay. That brings us to today's main item of the London Ambulance Service. This is the second of the 2 meetings looking at how the Mayor can support a more effective and transparent ambulance service in London. I can now please welcome Heather Lawrence, Chair of the London Ambulance Service NHS Trust, and also Garrett Emmerson, the Chief Executive of the London Ambulance Service. So welcome to the committee. Thank you very much for coming along. This is the open question. Perhaps you can, each of you, give me an overview of how the London Ambulance Service is currently performing, and what do you think are the challenges facing the London Ambulance Service? Okay, so it's performing well, and I will ask Garrett to give you specific details. But yes. I think you will know that in 2015 it was a particularly difficult time for the London Ambulance Service, and the CQC, one of our key regulators, put us into special measures. Well, I should say the other regulators did, but they made it inadequate overall. Since appointing Garrett and working with the new team, we have been deemed to be good overall with outstanding for care. And I should emphasise that the frontline services were always recognised for the outstanding care. But the organisation has now got systems and processes in place to ensure and assure that we can continue to do the things that we need to do in a safe and appropriate way. And one of the other things we've done is, I think before the focus was on frontline staff, and that's very laudable, but it takes, as you all know, 10 or 11 different people to get a crew out there. And so the importance of having our vehicles made ready, having good HR processes, training, risk management, all of those things are in place. And we have a new strategy which we can talk about, which I think fits very neatly into what everybody's seeing in London and where we need to be. And so we now have supporting strategies for the overall strategy that we're gradually getting, and working on the whole workforce. And one of the big issues is moving towards having integrated and interoperable IT systems with other providers, which is another year or so away, but we're working on that. So I think it's moved significantly, that it's been recognised. We're not a cause of concern to any of the regulators, and we are doing well on our performance. And Garrett?
Yes, so in terms of operational performance, the ambulance services in the UK moved to a new way of measuring performance, response time performance, last year. So we are still in the process of transforming our operational organisation to truly optimise that. However, currently we are meeting all of our main standards most of the time. We are typically in the top 3 of the 11 ambulance trusts in the country in terms of operational performance, and consistently meeting our most urgent response times, the so-called Category 1 time, which is a 7-minute average standard we are hitting consistently.
Okay, thank you. I know that there's a new initiative of hear and treat, or see and treat by the paramedics, right? How are we getting this message across to the Londoners that this is a new approach the London Ambulance Service is taking?
I mean, I think this is an absolutely key point that you highlight, and it's central to the strategy that we launched earlier this year, which is around seeking to do more seeing and treating on scene, recognising that treating patients on scene, providing you've got the right skills, the right equipment and the right capabilities, is better for the patient, is faster for the patient, and more effective in terms of being able to get on and deal with the next patient. So one of the big challenges we face in London, of course, is the volume of demand that is steadily increasing as the population grows, both the resident population and the jobs related population. So being able to see and treat more over the time, increasingly using the skills of our paramedics and developing those skills, creating new capabilities, new job opportunities, and so on, is good for patients, and it's also good for the wider health system, and indeed good for retention of our skilled resources, which obviously are a major concern to us.
Okay. Is there a target from the commissioners on the London Ambulance Service to reduce the number of patients being transferred to hospitals? I mean, in order to support the treat and hear?
Yes, and we have set a target for ourselves in our strategy over 5 years to look to reduce conveyance to hospitals by up to 10%. In terms of specific targets set by our commissioners, we have an existing target this year of a 1% reduction, but that's reflective of a lot of the work we're just beginning to do in terms of putting in place pioneer services in new ways of treating patients that we can explore later on if you wish. So it will grow, but it is very much a focused commitment to do that.
And just to add, I think, we are required to work with the 5 Sustainable Transformation Partnerships, as they now are. And clearly, as part of that, the pathways and how we do, and our trust worked very well and led last winter on queuing in hospitals and reducing demand with the winter room. And that's being used, again, it was seen as good practice, and London actually did better than the rest of the country.
Yes.
We saw a 15% reduction in overall delays at hospitals last winter, compared to the winter before, which was in contrast to most other areas of the country, which saw some degree of increase.
Great. I mean, you said that you work with the 5 STPs, but Brent CCG is the main commissioning body for you, isn't it?
Currently, on behalf of the other CCGs.
Right. So in the commissioning arrangement, does Brent speak effectively for the voice of all those 5 STPs?
So I think they have a very challenging role because, as you know, they have 32 other CCGs to get on board, and clearly the sectors in London can be different and CCGs can be different. So I think they have done a good job. Our view is the commissioning model will need to change, and that's a discussion we are having with a range of people.
Okay, thank you. And also, before I hand you over, is what can the Mayor and the NHS do to improve the arrangements for transferring patients to these services other than the A&E department after an ambulance call out? Well, I mean, what other options are there available to the ambulance service?
I'm not
apart from the A&E departments, sorry.
Sorry, could you just...
Yeah, what can the Mayor and the NHS do to improve the arrangements for transferring patients to the services other than the A&E departments? I mean,
so in terms of enabling more alternative care pathways, well, I think as the chairman says, key to that is to the close work with the STPs, the Sustainable Transformation Partnerships, and the development of the right care pathways in the right areas. Yes. I think a lot of this is about raising awareness of the way in which we work and the opportunities. The fact that a lot of our work isn't about transporting patients to A&E departments, it's about either treating people on scene or actually using alternative pathways, making sure that the right pathways are available at the right times and the right times of day. Being a 24/7 service, it's often in the middle of the night or the weekends when you need key pathways to be available. So I think supporting the work we do to raise awareness of that and have a wider public understanding of the nature of ambulance provision, because it has changed radically. You know, we're now in a position where we have highly skilled paramedics on ambulances who are capable of doing a lot of see and treat already. We only transport 63% of the patients we see to A&E today. That's down from about 74% 8 to 9 years ago. Okay. And as I say, we have a vision to deliver a similar step down again. And that's only possible through increasing capability, both in terms of our paramedics and our on-crew scene, and also in terms of pathways and ability to take people to other more appropriate care pathways.
Okay, great. Thank you. I'm going to hand you over to my colleagues.
Okay, before I go on to my section is about transparency and accountability. If I can just, before we start that, you said, Garrett, meeting all standards most of the time. Which standards don't you meet? And that are
there are a series of 14 ambulance quality indicators that are monitored on a weekly basis by the NHS England, and obviously, depending on demand, our ability to respond and the ability of all other ambulance services to respond fluctuates according to demand. When we see really high levels of demand, we take slightly longer, and when we see lower levels of demand, we often exceed them by quite a margin, and the overall standard metrics are around averages. So on the category 1, the highest category, we are consistently hitting the 7-minute target. On category 2, which is the 18-minute response, we have more of a challenge, and we are a few seconds over the 18-minute standard overall. That is largely because we are not yet fully adjusted to responding to the new standards. They require a very different mix of ambulances versus cars. They require a different range of rosters and times of crews on shift. That's a process that's taking a while to do, so that leads into a discussion we can have about the need to purchase more ambulances, because we need to go from, broadly speaking, a 50-50 mix between ambulances and fast response cars to 75% or higher ambulances, so that means buying more ambulances, and also need to change the rosters around, because obviously 2 people on an ambulance is very different to 1 person on a fast response car. So we're confident that when that is fully developed, that we will be able to meet all of those standards consistently.
And timeline on that?
We will be in a much better position by the end of this financial year.
Okay, lovely, thank you. So if I can go into my section now, which is on accountability and transparency. Who scrutinises you at the moment?
The Care Quality Commission, NHS England, NHSI, and of course our Patients Forum.
Okay, and across the board on both the way your finances and arrival times and
yes.
everything else?
So that would be NHSI and E on those issues, and our quality of our services, the efficient, effective, safe, are the Care Quality Commission.
Okay, and Brent is the one that commission is in charge of all the other ones. Have I got that right?
On behalf of.
Or on behalf of?
On behalf of would be the phrase.
Technically, we are commissioned by all 32 CCGs
yes,
in London,
but Brent takes the lead.
They appoint a lead commissioner to negotiate and
how
actually
often do you see them?
How
often do they sit and question or scrutinise you?
We have weekly teleconferences with them in terms of performance. We meet them quarterly at a strategic commissioning board and various other meetings. And similarly with NHSI, we now meet them monthly, bi-monthly, I beg your pardon, once every 2 months. Previously, we've had much more regular meetings, but the level of oversight has reduced somewhat now that we're in a much better operational position.
Okay. I mean, do you accept the need for the London Ambulance Service to become more accountable and transparent to the community it serves?
So I would say we are transparent. We have open board meetings. We discuss pretty much everything, and as Garrett will tell you, I'm always pushing for things to be in the open board meeting, not the closed board meeting. We now have alternate month board meetings because we are in a pretty good place. We still have strategies to develop, so we do those in briefing sessions separately. We live streamed our AGM. So,
sorry, you live stream?
Our annual general meeting.
Oh, right, sorry.
So I think we are as transparent. I sit on another board in London, Health Board, and I would say we are very transparent.
Okay. What are your views on bringing the LAS under mayoral oversight in a similar way to the Met and the London Fire Brigade?
So I think the difference is that a good probably 90% of what we do is about healthcare, and we've talked already about different care pathways, and the reality is our relationship with the other healthcare providers is crucial to getting it right. We take about 9,000 maternity calls. 10% of what we do is mental health. When it comes to what do we do that links to police and fire, it's about 1% of our activity. So whilst we see it as important to have blue light collaboration and working with the mayor, actually to get the right service for Londoners, we need to be integral to that NHS and shift of care pathways and funding mechanisms.
Okay, because on a survey that we did, the view was shared by including the patients forum that perhaps there should be more scrutiny. What would you say to that?
More scrutiny?
Yeah, well, that it should be taken under the guise of the Mayor to look at.
Well, you know, I'd go back to very little of what we do is high-end stuff. Yes, we dealt with 6 major emergencies last year and worked very effectively with blue light services and the Mayor in London. But of the 1.2 million incidents we do, is it 99%? It's a very high percentage, are about health, and they are people who fall over, have complex needs, are mental health clients, and you know we're working on alternative pathways. And if you look at our strategy, and that isn't the Mayor's sort of main area of interest, as I would understand it. So I think we are very heavily scrutinised. When we're in special measures, I think
my vision is that it shouldn't matter whether a patient rings 999, 111 or contacts us online. We'll get them to the right level of care, whatever that may be. So that's very much the focus of our strategy. That's very much the focus that I think the whole healthcare sector wants ambulance trusts to move in. If you read, you know, the 5-year vision, you read the recently published Carter review of ambulance services across the NHS trust. This is, you know, we are very far from an organisation that is about transport solely. Yes, we have a transport element to our clinical service, but actually our primary role is to provide frontline clinical healthcare services for many millions of Londoners every year.
So actually picking up on an earlier point, actually what could the Mayor do? There's still a perception out there that we are a transport service, but these are professionals, healthcare operators in our service, part of the health system, and need to be more integrated with urgent and emergency care across the health sector.
Yes, no, I think we understand that. Do you find scrutiny helpful?
Always.
Of course.
No, I mean, quite seriously, it's invariably helpful. I mean, the survey that you carried out, that I'm sure you'll want to talk to, was really helpful to us. It gave us an opportunity to talk in the media about some exactly the things that we've been highlighting around the nature of provision, around the way we deliver healthcare services. So absolutely, it has to be.
Andrew, you want to come?
Could I just ask about that 1% figure that you just mentioned to us? You're saying only 1% of your activity is with the other emergency services. Is that correct? Is that
yes, I mean, let Garrett
typically in terms of serious incidents that we respond to jointly with either the Metropolitan Police or the other police services or the Fire Brigade or both, that is typically around 30 to 50 events a day. So that wraps up to around 15 to 20,000 incidents a year. We actually respond to 1.2 million incidents a year overall in terms of all categories of health.
In terms of the origination of some of those calls, we were told on previous scrutinies on this committee that a vast percentage of the dispatch was directly via contacts with the police. So that doesn't to me look like 1% to me. It looks to me like you've got quite an intimate relationship with the police.
We have quite an intimate relationship with the police in terms of dealing with issues. We have a desk in our control centre that is linked directly to the police, and we deal with a significant proportion of calls and contacts from them. They don't all necessarily result in a response or incidents. They can frequently be advice.
So there is quite an overlap in.
And the incidents that we deal jointly with them are
that 1% belies.
They're obviously at the more significant end of what we do. You know, they are the bigger, more serious incidents naturally, but they represent, in volume terms, a small proportion of what we do. You know, we respond, for example, to 100,000 or thereabouts mental health related calls a year. Some of those we receive through the police, from the police, but they're not a co-response.
They're not co-response. I mean, you're not on the scene with them. Thank you very much. Sorry to take up that.
Thank you. Umar, over to you.
Good afternoon. Mr. Emmerson, you talked about the survey that you did being very helpful.
Did.
Yeah. This have also showed that many Londoners have misunderstandings about how the London ambulance service works and should be used. Now, note to some extent, we already touched upon this area of community engagement and public awareness in your earlier answers, but can I formally ask you for your views about the findings of the survey that Londoners have misunderstanding about how your service works and should be used?
Okay. I think, first of all, I'd like to point out that we're very gratified by the degree of confidence that Londoners showed in our overall provision. To have a survey that says that nearly 90% of Londoners have confidence in what we do was really very assuring and is very much appreciated by those of us who work within the service. But you're right, it highlights a number of issues, particularly around younger people relative to older people being less confident or feeling they know how to use the service correctly. That's the kind of thing that is really helpful because it helps us focus our work. That's not something that's completely new to us. We do target an awful lot of what we do in terms of public engagement activity towards the younger end of the population. We did 540 public engagement events last year across the service. Nearly half of those, 243, were in the 11 to 18 age group, targeting those people that perhaps have less confidence to use our services correctly. And we know that it does result in some really good positive response and some really good success stories in terms of younger people who now know how to use the service correctly. But there is a limit to what we can do, I suppose, is probably the key message.
But it goes back to the strategy, doesn't it?
Yeah.
Sort of linking 999 with 111 so that we can steer people to the more appropriate response. And then it can be up or down graded according to what the problem is.
Mm-hmm. I mean, you talk about confidence, but and also you talked about raising awareness. I think again, to you, Mr. Emmerson, widening public understanding. But the patients forum certainly don't seem to be too impressed. I mean, they say that engagement with the public and patients on your new strategy has been minimal.
I think we would disagree with that, actually. We have engaged with probably nearly 30 organisations and we engaged several times directly with the patient forum. We produced a statement of intent document in advance of our main strategy that we published widely, communicated on, and indeed had responses back from the patients forum and many other organisations before we produced our final strategy in the spring.
I mean, the briefing note that I have says that there was only one meeting attended by 12 people. And 3 of whom were forum members, and 3 office meetings between the forum and your strategy team?
We would disagree with those, but I'd be happy to get you our view in terms of the extent of our engagement separately.
That would help. So, I mean, just thinking ahead, we've done this survey, we have you here before us. I mean, how do you intend to further engage the public in light of our survey findings, your own experiences, with your plans to transform the service? Can the Mayor be of any help?
The starting point is we are developing a new user engagement strategy, saying how can we engage more widely with the public and other organisations, and that work is in train. Clearly all communication is good and different channels, and we use as many as possible, but we will be looking to use a much wider channel than we have before.
I mean, I do think this is one of the areas where the organisation is transforming itself. It's certainly true to say, and I think we would accept that in the past we have been quite an insular organisation and have not engaged widely. However, I think that has changed widely. We're engaging much more extensively across the healthcare sector, and the Chairman's already spoken about the need and the work we're doing across STPs and wider healthcare sector. We've always engaged, obviously, closely and worked closely with the emergency services, but I think now in terms of broader London engagement, we are getting much better at that. We have a very good working relationship with the Mayor. The Chairman and I meet him on a regular basis. We work not only in terms of...
With the Mayor?
With the Mayor, yes. Yeah,
how often is that? Is it
about 3 or 4 times a year. And we work not only in terms of external engagement and public-facing activity, but we also work in terms of collaboration across the GLA group. Indeed, not 2 weeks ago, we were represented at a group that is looking for the opportunity to work more closely across back office services, support services, IT, and so on. So I think there is a much greater degree of collaboration, both in terms of organisational engagement and in terms of public engagement.
And an example would be the maternity work that consultant midwife has done. Do you want to talk about that, with engaging with groups and getting, you know, what mothers and the supporting groups, what their views are? So in looking at our pathways, hearing from the people who are using the service, we're doing much more of that in all the pathway work.
And I think particularly in terms of specific patient groups, maternity is exactly one case, but we've done similar work with mental health patient groups. We've done similar work with sepsis and sickle cell society. We're in a very different position in London in terms of something like sickle cell, where we have 70% of the UK's sickle cell susceptible population. So it's absolutely right that we work specifically with those groups. So I think it's very, very targeted in terms of identifying issues within patient groups. We organise and run many sort of focus groups and workshops specifically in relation to that, bringing in appropriate groups, groups of carers, groups of patients, to try to continually improve the organisation. Part of the transformation, I think, has been to become much more of a learning organisation that actually learns and encourages more work to go on to identify issues and learn from them to improve care. And we're seeing quite a lot of the benefits of that, I think, in terms of, you know, the quality of the care, and that's supported really by what the CQC have said in moving us to being outstanding for caring.
And one of the areas of good practice they noted is that at the board meeting, in the open board meeting, as a message of our transparency, alternatively we have a patient story or a staff story. And one of the patient stories was a sickle cell patient. It's in the open meeting. They explain what the pathway was like. We work with the Sickle Cell Society, consultants in that area, and we listen to what that patient story was and how we've changed our pathway accordingly. So we take the good with the bad. We've had a mental health patient tell us how it was through video link. So that's where actually I personally learned about mental health cafes, which helps us take it forward. So as a board, we're very open to listening and learning.
Thank you for that. I heard a lot about you talking about linking with organisations, but how are the public facing? I mean, if I ask the member of the public, what do they think the job of the London Ambulance Service is, they probably will say to me is to take me from place A to B. How are they getting the message that you are more than just a conveying service that you...
As you know, if you're a hospital or a general practice, you have a group of patients who know specifically what you do and you have an ongoing relationship with them. That's not the case for an ambulance service. People, as you know, call us when they need us, and it may be once in a lifetime or never. So it is something we have to work on, which is why working with the patients and the groups in the pathways, and although we've got, I think it's 5 pioneer services at the moment, we're going to extend those, and we know what the next 2 will be. So trying to get at the public that way, and it is perhaps a way, you know, if you say, what can the mayor do? It goes back to any discussion about ambulance services, not referring it as a transport service at all, but as a health service with healthcare practitioners who are professionals and offering a professional service linked to the rest of the health service.
And this transformation or different way of working, how are you communicating this to the GP population? I will come to specific cases in a minute, right?
Yes.
But how are you linking up with the GPs? How are the GPs understanding the new role of the London Ambulance Service?
So, I mean, that's about our new strategy, which is brand new this year, a few months. We've only launched it for a few months. And we do have to work through the CCGs as a vehicle to GPs, but others as well, other healthcare professionals. It's a journey that isn't going to be quickly fixed, I don't think.
But I think that's also where the opportunities are huge in terms of us getting more involved in 111 integrated urgent care. So, you know, we are now not only answering 111 calls, but we're also providing GP advice, clinical advice, pharmaceutical advice. We have direct access in terms of managing out-of-hours GP appointments through 111. So it's a much more enhanced level of clinical care. So I think it's about joining up those pathways. The sort of catchphrase on our strategy is about becoming London's primary integrator of access to emergent and urgency care, and urgent care. We're the only London-wide trust. We're the only people that are really in a position to do that across London. So it will take some time to develop and evolve, but I think given, as Chairman says, we're only 3 or 4 months into the delivery of our strategy, we've already seen some major steps forward with the implementation of the full 111 integrated urgent care service in North East London, and we're now geared up to the mobilisation of a similar service in South East London. So all of that comes together. I think also more broadly, you talked in terms of what can the Mayor do to support us in terms of public awareness, public engagement. One of the things that the Mayor does do very well in supporting us is in terms of public campaigns, particularly around Christmas and alcohol and so on and so forth. They're the kind of things where we can really benefit from a joint message, an integrated message. And of course, things like this. You asked, do we enjoy scrutiny? One of the reasons we do enjoy scrutiny, because it's an opportunity to get those messages out. And there are some key misconceptions, if you like, that we do want to change about the nature of the way we work, about the fact that our ambulances and our crews are on the road 24 hours a day, 7 days a week. They don't wait around in ambulance stations waiting for a call. They're going literally from call to call because we're very busy, very highly utilised. But what it does mean is when you need us most, we're literally around the corner, so we are able to respond quickly. It's one of the reasons why our response times are so good, particularly for the most urgent calls. So I think all of that helps and comes together, and the media, in terms of having a higher profile, I would say, in the media than perhaps we've had in the past, has enabled to get those messages out. So for instance, in terms of the publicity you did in relation to the survey you launched, on the back of that, we were able to do some significant media on Talk Radio and through other channels that starts to highlight those issues I've just described. The fact that the Evening Standard was able to put the launch of our new strategy on the front page and to leave it there throughout the edition, I think illustrates that we are getting our message through to the public in many more ways, much more effectively than perhaps we have done in the past.
Thank you. I'm sure this is some area we'll explore, but I know one of my colleagues will be picking them up, okay, so we'll come back to them. Andrew, over to you.
You've touched on some of my questions already, so if I go over them again, just the same answer. What sources of information held by other public services would help the London Ambulance Service plan and operate its services more efficiently? And because obviously the Mayor has a control over a number of data sources. We're just trying to get an idea of whether or not they'd be useful to you.
We made significant use of data held by the Mayor's Office, GLA and TfL and other bodies in terms of development of our strategy to understand the planned growth of London, the nature of the demographics, the nature of the population growth, and so on. All of that data is really useful to us. I think one of the things that I was really keen that we did in terms of developing that strategy is that we didn't look short term, we looked long term, and we understood 20 years out what the future of London looks like, and the challenges that face us, to be honest, are the challenges that face many other public sector bodies in terms of providing services, increased volumes of services in a more intense, densely populated environment, and so on. So to be able to understand that and understand where growth is taking place, because growth is not taking place evenly spread across the whole of the city, helps us greatly in terms of our future planning. So we do make quite a lot of use of that close working relationship.
Have you been involved in the Mayor's Smart Cities data programme, which is there to use data to make the city run more smoothly? Not
personally, and not to my knowledge, but I could stand corrected on that.
And how does the one of the things that the Mayor's quite big on is volunteering.
Yes.
You've got a number of volunteer responders, as I understand it. How does the London Ambulance Service intend to boost volunteering, and how could the Mayor help? Just bearing in mind we have quite an expertise in finding volunteers.
So that's a very interesting question, because it's something that we are developing at the moment. We've done some consulting with our staff on volunteering, and the volunteering strategy is about to come to the board. And I think, as you will know, we have co-responding volunteers, but where we do want to, and we want to look at volunteers linked to our pioneer services, the issue for us is about recruitment of Londoners. And we see a cohort, if we can get young people coming to be volunteers, it should help. We want to help attract people into the service. And that is an area I think we would both be keen to see developed.
Absolutely. I think we are in the process now of shaping a volunteer strategy. I think we've both seen for a while that it's an area we want to develop. Yes, you're right that we have two sorts of volunteers. We have community responders and we have emergency responders. The former are community ununiformed in normal cars. The latter are fully trained uniformed and blue light capable emergency responders that support our frontline paramedic crews in terms of being first on scene. But I think we can go a lot beyond that, and I think our vision is to have the ability to bring in volunteers right across the service of perhaps all ages and all levels of commitment, through from perhaps more junior volunteers in terms of developing what I'm sure won't be called a cadet scheme, but that sort of thing in terms of developing perhaps future clinicians, through to members of the public of all ages that perhaps want to dedicate a small amount of time a week, for which potentially through the development of some of our new services we could have a lot of opportunities for people to get involved in many different ways, through, as I say, to the more sort of the more higher levels of commitment that involve significant training and significant work alongside our frontline crews. So there is a lot of opportunity. One of the questions we are debating at the moment is how we do that, and you're absolutely right to point out that the Mayor has a lot of opportunity to a lot of ability to bring in volunteers. So do some of our other partner organisations, some of the charitable trusts we work alongside, some of the other major trusts who also have significant amounts of volunteering. And I think there's a recognition in the recent planning away day that we held that actually there isn't a lot of sense in all of us trying to do this separately, and we should look for ways to join up, but we haven't yet got to an answer of how that should work yet.
Have you had a conversation with Team London?
No, not directly, not at this point.
I mean, you should really ask questions, but it seems daft not to.
No, I think if you can put us in touch, that would be really great. Yeah. It's a very live issue for us, I think, in terms of developing that strategy.
Yeah, and you're quite right. Why reinvent the wheel when people have been through that pain of trying to get that kind of engagement? But it's something you'd wish to do, to talk to Team London?
Yes.
Definitely.
To what extent do... It's a rather obvious question, this one, but to what extent do London's congestion problems affect ambulance service operations?
You're the expert on transport.
I should answer this one, shouldn't I? Obviously, London is a very densely trafficked city, and that has inevitably some implication on the management of all activity, all mobile activity. I think we're obviously in a fairly fortunate position as a blue light responder that we are able to use blue light capability to get to our most urgent cases quickly. So our response times are very quick. We do meet the most urgent response times in terms of the 7-minute response. The nature of, without getting too technical, but the nature of the way traffic is managed in London is actually quite helpful to an emergency responder because of the extent of the traffic control and the traffic lights and the grouping of traffic. It means that we can actually use the traffic lights that are red to get to the front of queues and safely get across junctions and make progress. And actually we do that quite a lot more effectively than you're perhaps able to do that in some other parts of the country. We actually got approached, interestingly, by a company that was working with in a city elsewhere in the UK, where they were looking at whether they could join up ambulance tracking with the control of traffic signals to help smooth the flow of the ambulance within the traffic to speed it up. Actually, we'd probably find that a disadvantage because the ability for us to manoeuvre around the traffic, get to the junction and get across it on blue light is probably more effective for us. So it's not as big a problem as you might think.
Yeah, congestion sometimes assists you.
It could do, yeah. I wouldn't say so much congestion. I'd say it's more the carefully managed nature of traffic in London.
So, how would greater access to TfL's traffic data improve your efficiency?
Not that I've been able to determine in the last 18 months since I moved from that world.
So everything that I'm assuming you use live data of where there are problems.
Yes. Yeah.
Everyone does. But
yeah.
There's no extra bit that you would need in terms of to perform.
No, I've facilitated a number of discussions between TfL's traffic managers and our crew and our operations staff to understand whether there are areas where we can improve through joint activity. We work very closely together, both physically as well as in terms of relationships. So I think that that is quite a productive working relationship. In fact, more generally, across the two organisations, since I've taken the job, we've been able to bring together a large number of events and initiatives that have come about jointly through TfL activity. So whether it's on the tube in terms of promoting activity to encourage people to, if they fall ill, to wait till they get to stations and so on, which is a big challenge on the tube. We've been able to very actively help in that. That helps us too in terms of getting to patients quicker. We've more recently done a joint initiative with the London taxi trade around trialling defibrillators in taxis, which was again something that that we work together jointly with the Mayor's Office and TfL as well as the London taxi trade. So I think there's a very good working relationship, as you might expect, developing there.
Quite recently, within the past couple of months, Uber have opened up their data, their traffic data. Is that something that you'd probably want to have a look at?
I can't immediately see whether there'll be significant benefit, but on the other hand, I would certainly have no reason not to want to look at it in case that, you know, if we could make use of it, of course we would want to.
I know somebody you could call. Let's move on to the integrated health and social care. To what extent, you did describe your...
Can I just comment before you come to... are you going to go over to question 5, are you?
Yes. Sorry, have I missed something out? I obviously have.
That was Joanne's question, wasn't it?
No.
Sorry, but I just wanted to ask you about the TfL's weather data, whether you access that data or does it have any impact on the ambulance service?
I think TfL requires weather data of probably a far more granular nature than we generally require. Obviously, in extreme weather and so on, that can become useful. But if our need for weather data is more around advanced planning in terms of understanding when it's going to get particularly cold or particularly hot and the implications in terms of demand, whereas TfL's weather data is very granular in terms of different parts of town and very live in terms of almost hour by hour in terms of freezing points and things like that. So I think we have very different demands in terms of weather, but nonetheless, I've learnt in many jobs over a long career that you can always explain performance, whatever you're doing, in some way, shape or form, by the weather.
Okay, thank you. Carry on.
Let's go. Yes, so you mentioned earlier about your involvement with the emerging STPs. So, to what extent have you sat in on the meetings, involved yourself with those plans? Because you originally said to us that it wasn't that active an involvement. Is that something that's going to...
The STPs in London are at varying degrees of development, and they have some major issues to address that are, how should we say, more acute focused or not involving us. Where they are of particular interest is hospital handover and obviously urgent care. So we do have a sequin in relation to, this is one of the, how do you describe a sequin? Quality improvement target linked to involvement in STPs, but I would say from the executive side it's greater than the non-exec at this stage.
I think so. I meet regularly with all of the accountable officers of the 5 STPs and have productive discussions and relationships with them. My colleagues sit on and go to urgent emergency care boards in the regions and indeed the London-wide operation, and we have a team of sector engagement managers, one in each of our 5 operating sectors, which tie in with the 5 SDP regions, who do a lot of the close day-to-day relationship work and a lot of the building of care pathways and so on. So that there are relationships at all levels of the organisation.
And that you go on about those different care pathways, of course. Do you need further support from the wider healthcare system to progress your plans on more tailored services?
Yes, very much so. I think in terms of the 3 main themes in our strategy, the 3rd theme is very much around developing that partnership working and developing those care pathways, and an element of the lowering of conveyance that we might be able to achieve is very much dependent on that partnership working effectively.
It sort of goes back to the 33 CCGs, and you can't have 33 pathways for, say, mental health. We might be able to cope with 5, one for each sector, but it's really very difficult for crews who are in different patches to be having to think which pathway today for this particular client. So that's where the close working comes in. It's really important they know what the pathways are, what the possibilities are, and that we're looking at the whole pathway together.
So are you? We don't want to be worried, therefore, that you haven't got that you do think you've got the administrative capacity to feed into those STPs and get what you need out of them, because that wasn't we were told before that the response that we got was that the participation in the strategy and service development had been previously limited.
Well, I think if you talk to most chairmen in London, they would say that at the stage that we've been at. As you know, they're new formed organisations. It's a development in process.
Right, thank you. And what do we need to revisit the approach to alcohol-related incidents?
Probably, I don't know.
In any particular way? I mean, I think to answer that generally, I think as the chairman says, the answer is yes, and it is in terms of future pioneer service areas. It's at the top of the list that we want to look at.
Well, you yourselves say that alcohol is a factor in around 6% of the call-outs, which is a significant number. One paramedic has been quoted as saying that of the injuries that they've seen, it could be as between 60 and 80% in the West End and central areas are related to alcohol. That's an anecdote. Admittedly, that's not data, but it does seem that whilst certainly this committee has seen activity taking place with regard to alcohol abuse and the London Ambulance Service, we don't know whether or not it's actually getting any better.
I don't have any data that could either support or contradict that, but I think you kind of hit the nail on the head a little bit when you talked about alcohol being a factor, because often alcohol is a factor in an incident or an injury that has a physical component to it, or indeed a mental component, and to treat alcohol as a type of incident on its own, I think could be quite misleading, and one of the reasons why we have to be kind of careful. But you're right. Alcohol is certainly a factor in incidents at certain times of the week or the weekend, and in certain parts of the city where it's higher than overall. So looking at an average figure is probably not a lot of help either.
We were talking prior to this meeting amongst the committee about the alcohol services, and certainly I'd be quite eager to come and see how it's working, perhaps just prior to Christmas, that awful period of time where it must be a London Ambulance Service. Would that be something that would be arrangeable for them?
Absolutely, yeah.
I think I would sort of be just mindful. When I talk about alcohol services, I'm thinking of the services that people are referred to when they have a known alcohol problem, which is different to we're trying to deal with people who present, on Fridays and Saturdays in particular in the centre. And what I've read and learnt is that historically it would only be Saturday night, but it seems people's behaviours after work have changed, and the combination of drugs and alcohol make it a different problem. So we deal with it when it's a crisis rather than in a preventative way.
Yeah. So in many ways it can be a factor or the main reason.
Yes.
There's
absolutely.
a number of things there, isn't it? But certainly it's something that this committee has had an interest in the past.
It's a big challenge.
And we wouldn't, I just wondered whether or not you felt it was worth revisiting. And
well, I think
yes.
It's certainly worth revisiting from the point of view of campaigns, which is a big area. And I think we've had a view for a while that campaigns in relation to alcohol need to be fairly direct to get the message across. And of course, there are conflicting priorities in terms of how you want to get the message across. If I'm a publican or a licensee, I might have a different view about how that message got communicated than if I was an ambulance service. So there is a public debate about how best to communicate the message of safe, responsible drinking, which is obviously something that we support.
to be fair to publicans, it's not actually in their interest for their customers to be blind.
No,
It's
but we've
their
certainly
interest.
been involved in
Yeah.
debates in the past about the nature and tone of what an appropriate campaign could look like.
Thank you very much.
Thank you, Andrew. These questions were under the section of integrated health and social care, and I want to explore one or two other themes. How is the London Ambulance Service affected by the lack of access to community services for the mentally ill? I mean, how much does that take? Must impact on your decision making when you're called to a mental health case. The impact of available social services. How does that impact on your decision making, whether to convey the patient to hospital or leave them at home?
I think quite significantly is the short answer to that. If you read the recently released Carter review into ambulance services, you'll see that not only do we have proportionally more mental health patients than any other ambulance trust, regardless of size, but also we end up having to convey more of them to hospital at the moment than any other trust, and some of that is about the availability of alternative pathways. And I think in the past we have struggled to build those relationships. However, I do think that's changed. I think that is changing, and we now have a very positive working relationship with the mental health trusts in London, and we're working hard to deliver a number of new pathway opportunities, including the Chairman's already referred to the development that we'll soon be able to take patients to mental health crisis cafes as an option, which I think will make a difference. We now have mental health nurses in our control room providing bespoke advice to crews on the ground. So I think there is a lot of opportunity and a lot of potential for us to change that, and I think that could make a big difference in terms of the overall percentage of people that we're able to see and treat in the future.
And I think it links to what we were trying to describe before, is that over the last 2 years we've been taking a more strategic and inclusive approach to all of these things. So not trying to do it on our own, but working with the mental health trust. So Garrett goes to the Chief Executive Mental Health Trust meeting. So we're much more outward facing and working with people rather than thinking, well, crisis, and that's all we can do. So the mental health cafes, as they evolve, are a really exciting opportunity, because if you are in crisis with a mental health problem, A&E is probably not the right place for you. A police cell isn't either, and so it's not good for the client, it's not good for the A&E staff or the police, and it's not good for our staff. But being able to take them where they're known clients to somewhere that's more calming but the skilled people are there is much better. So we see that as something positively moving forward.
And of course, the other cases, for example, you've been called for a patient who's fallen out of bed, for example, an elderly patient. You probably make an assessment, they haven't broken any bone.
Yes.
But how does the availability of social services for that patient impact on your decision making? What's going to be preventing the patient falling out of bed again, or what social care is available in the community? Does that impact on your decision making? So
there is work with CCGs on fallers and knowing who the fallers are and where they are and how frequently they fall, and different pathways. And actually, as you all know as a GP, the care homes and nursing homes are part of that. And I'm sure you've been called to a nursing home because somebody's fallen, and it's not really appropriate either. For our crews, having access to the either Coordinate My Care record, or as we get them onto an electronic patient record and they can access the record, will help them keep people at home. And then we talked before about volunteering. I can see occasions where somebody may be able to stay at home, but the health or social care support can't quite come. And if we had volunteers who could go and sit in with them and maybe make that cup of tea.
Are experts in treating with emergency situations, but they're not doctors.
No.
And I've had cases referred to me where a GP has called the ambulance crew to convey that patient to the hospital. The ambulance crew has arrived there and has made a decision not to convey the patient, to override the GP, which causes anxiety and stress, right, to A, to the patient, B, to the GP. How do you address those conflicting needs, right? Here's your crew, right, under a directive or under maybe incentive to delay conveyance into hospitals. But here's a GP who's called an ambulance thinking this patient needs to go to hospital, and that discussion is taking place in front of the patient. I've had this representation to me and I'm worried about them.
Yeah. You raise a very tricky issue because equally what happens is a GP will sometimes instruct a paramedic to do something they're not trained to do. So this whole relationship bit is really important. One of the things we have is our clinical hub. So we have doctors in our clinical hub. We actually have doctors in the 111 service, so they can take advice. But I would say where that happens, we do encourage the healthcare professional to raise it as an issue, and we will look into it. Because sometimes it will be that there's a communicate, you know, as you would know and I know, it's a communication issue of understanding where the other person's coming from, getting a mutual assessment. So it's difficult to respond to an individual case here, but we do see where people are concerned, they will raise it as a healthcare professional, we will look at it and respond, and if there are development needs for our crews, we will do that. But equally, it has come to our attention quite recently that it is important that our crews, if they are responding to a 999 call, that they don't follow instructions from somebody else, particularly when it's a bystander who happens to be a GP, who's not even the patient's GP, that they contact our clinical hub and take advice, because it's a risk, and you raise a difficult issue.
Yeah, I mean, I raise it because it is an issue on the ground,
yes.
and something which I think
we
causes
would
a problem.
urge people to let us know, and we will look at them.
Yeah, I think one of the other areas probably worth talking about in terms of healthcare calls is that we have an almost unique visibility across the system. So one of the things that hospital trusts, acute trusts, will often say to us, you know, you're sending too many patients to us, and why can you not manage the conveyance more fairly or more evenly across A&Es and so on. And frequently when we get asked specific questions about specific times, it's the healthcare transfers that are predominantly creating the surge in transfers, because there isn't visibility at the GP end in terms of, you know, this patient needs to go to X hospital now, sort of thing. Well, there's already 10 ambulances there because 9 other GPs have made the same call, and we're in the middle of winter. So actually getting better visibility and better ability to understand where we can be flexible across the system and where you absolutely can't will improve the flow, I think, of patients through the system much more generally.
Okay. And the other thing that's been raised with me from the Patients Forum isn't your call centre, for the emergency centre, has said that it calls a category 1 or 2. This is in relation to prisons and the immigration removal centres, that the ambulance arrives there within 7 minutes. But then you have a delay at the gates of the prison or at the immigration centre of accessing the patient and conveying that patient to the hospital. How often does that happen? And are these breaches recorded by the ambulance service?
All breaches are recorded.
That's not a specific issue that has been raised with me before, but I'm very happy to take that away and look at it.
Certainly, I will send you the copy of the letter which I received. This letter was sent to the Director of Health and Justice Services Commissioning, England, but this has been raised with me by Patient Forum, right? And I will certainly share this letter with you, and hopefully you'll get back to me.
Yes, very
about
happy
the response
to respond to that.
Thank you. Can we move to question number 6?
Yeah, that's
Susan?
me.
Yeah.
Collaboration with other services. So how has the new duty to collaborate affected your relationships with the Metropolitan Police and the Fire Brigade? And what specific steps has the London Ambulance Service taken in the last year?
So there's historically been very good working relationships across police, fire and ambulance. And I think, if anything, that's been enhanced in the last year or so. And there is a blue light collaboration group that they're working on. We have our own governance arrangement, so we fit it in, and actually in our organisation it goes through one of the subcommittees of the board, because clearly we can't have it operating outside. And we look at things, but we do have to look not just at the blue light collaboration, we have to look at other ambulances and the rest of the health service, so we have to weigh up what's the best thing to do. But Garrett, you've got some specific examples?
Well, yes. I mean, I think it's probably fair to say that we already had a very close working relationship with the London emergency services, and that continues. I meet regularly with the 2 commissioners of the Metropolitan Police and the London Fire Service, and also with the Chief Constables of British Transport Police and City of London Police. So that relationship is there, and that's reflected all the way down. We have, between ourselves and the Met and the LFB, we have an overarching strategic agreement that focuses on 6 themes that are around prevention, response, control services, people, support and infrastructure and strategy, and underneath that there's a lot of joint working. I think we're currently doing a piece of work jointly funded by the Home Office around the future of control room operation, for instance, across the services and what opportunities there are to integrate that. We're also talking on a whole range of issues from IT to people management. We're currently talking about whether there's greater scope for collaboration around occupational health support across our services. So I think there are multiple avenues that we are exploring to work jointly. But Chairman, again, is right. We're probably in a, well, not a unique position. We're in a very privileged position that we have opportunities to collaborate across the emergency services world, but we also have opportunities to collaborate across the health sector world in London that we do, and of course across the ambulance sector across the UK, and indeed a significant part of our more specialist emergency service response we provide as part of a national response in collaboration with the other ambulance trusts in terms of our hazardous area response teams, etc. And we train very regularly with all of our emergency services colleagues, not only sort of the major training events that you might see in the media, but on an ongoing week by week basis. So I think, has it changed the nature of the relationship? I don't think it's changed the nature of the relationship. I think it's probably intensified and focused the mind on are we doing everything we possibly can? Are we taking advantage of the opportunities that we do have to work together?
Okay, where do you think it could be even better? Where do you wish it would be better?
I think if I saw a big area or a big gap, we'd be doing something about it and we'd be talking about it. I think the opportunity for it to get better is sustained working over time. As we do some of the things I've just been talking about and bring them to fruition, we'll understand where the opportunities are to do more. But I think I think it's a very healthy working relationship. I think I've been very impressed, frankly, of the depth and breadth of the relationship that we do have across all 3 services.
If we look at estates, because obviously things are getting more and more difficult financially as we go forward with everything, and I'm a great fan of collaboration in these areas. I mean, what do you think more about sharing estates with, say, the fire brigade, because they have so many?
We do. We're in Union Street.
Yes, no, I know, and I've been to Stratford, and I was very, very impressed with that.
That's the cycle response unit, isn't it?
Going forward.
Yeah, and I think there are opportunities like that, and we do, as you say, we do use joint estate for standby response points and things like that. I think if your question is directed more around major operational bases, I think what you've got to remember is that we operate, as we've discussed earlier, in quite a different way, in that we have vehicles on the road 24/7, and our requirement is actually to have facilities that can produce and service and maintain those vehicles and provide facilities for staff at shift changeover points to get out on the road, and actually we need to do that in a more concentrated way. We make ready vehicles at 14 locations across London and put them out right across London. They go operate either from main stations or substations or standby points, but the actual the business of preparing ambulances, putting all the kit on them, making sure that they're properly cleaned and infection free and so on, and providing the equipment for the crews and so on is a much more sort of centralised approach than it would be for a fire engine response, where the requirement is much more to have vehicles available locally.
Okay, I mean, is there any area that you're being slowed with the desire to incorporate more by the police or the fire brigade? Are you finding any resistance anywhere?
No, I don't think so. So I think that there are genuine opportunities where we can do this, particularly in relation to standby points. So a key part of the
facilities, quite frankly. Yeah. I mean, there are so many fire stations in and around London.
Yep.
I know, for instance, I have somewhere at the bottom of my road where an ambulance car is constantly at. there's no facilities there. I'm just thinking if you have people in standby areas, would it not be more help if they were in more fire stations where there's...
Well, I think the first requirement is to make sure that they're in the right point so that they can get to patients within the time requirements. So I think that does constrain where we put stations. So there's no point in having a fast response car in a fire station if it's the wrong location to get to patients quickly.
No, I accept
so
that.
So there are some limitations like that. But notwithstanding that, I think there are opportunities to collaborate across a number of public sector areas. It's not just about the fire service or indeed the police. There's actually TfL, there's an opportunity, Network Rail, there's an opportunity. We're talking to all of those public sector organisations.
Is there a desire to push forward from the NAS point of view?
Yeah, but as I say though, I think it needs to be within the context of what works in terms of the service that we have to provide patients. But yes, within that context, absolutely.
Okay, thank you.
I thank you for this. I just want to talk to you a bit about the emergency service network. This was commissioned in 2011 and it's now been delayed for 2 years, I understand.
This is the replacement for Airwave.
Yes.
Yes.
Yeah. So, are there any ongoing costs for the London Ambulance Service for that delay?
Not directly that I'm aware of. Again, I could stand and be corrected that. As I understand it, we have contracts, or there are contracts being put in place that will enable us to maintain the existing system, have use of the existing system for a number of years. So,
yes.
And the existing system is still working for us effectively.
So it's still working satisfactorily and the costs of repairing or replacing hasn't gone up?
Now, I think that the important thing is that when we have a replacement system, it's a replacement system that delivers everything it needs to, and that we don't have a problem with a new system.
And are you confident that the new system will be reliable and that we can get it delivered on time, even though it's already 2 years delayed?
Yeah, I probably not. Haven't got the level of detail that I could give you that assurance as I was sat here, but we're working very closely with the Home Office and with the other emergency services to make sure that that's the case.
Okay, thank you very much. Chair?
Yes, I want to ask about workforce retention and recruitment. From, I think, your board papers from February this year, that noted that your vacancy rate for paramedics was at around 10%, and in your call handling staff, that was around 20%. Are those still around about the right vacancy rates, or
no.
Have you got up-to-date figures?
Yeah, our vacancy rate for paramedics is actually very low indeed now, because we have been focusing on recruiting them, so we are almost at 0% vacancy rate for paramedics if we include our advanced paramedics and so on in that. So that has been a deliberate decision. However, that is only half the story, because for emergency ambulance crew, which is the non-registered clinicians, we still have a significant vacancy rate there, and some of that is because we've been focusing on recruiting in paramedics in the short term, so we now need to go back and recover that. In terms of call answering vacancies, that is also much lower now, and part of the reason for the figures that you quote is because last October we took a decision to increase the number of posts we had by 73 posts. We have about 400 call answering staff. We increased by 73. We were about 30 short at that point, but then we went to 103 short, and we've been recruiting up to we're now about just under 40 posts short, and by Christmas we'll be about 10 posts short. So that's been a process of creating the capacity to train, to recruit and train more people, because broadly speaking we had the training capacity to sustain turnover and sustain the establishment we had, but actually we've had to build a greater capacity to increase to a high level, which has taken a bit of time, and there are constraints not only around the numbers of trainers but also the physical space to train people, and the IT, the kit to enable us to train people offline so that they're not using live equipment whilst we're training them how to be call answerers.
Well, that's very positive news, and I know particularly with your paramedics you were recruiting abroad, I think from Australia, New Zealand. Do you have any breakdown as to how many of your staff are EU nationals, for example?
Yes.
I don't have the exact number, but
Yeah.
relatively few. We are probably much less exposed than other sectors of the health sector, of the health service, to EU nationals. So we, in terms of risk, but we do. Most of our overseas recruits have historically come from Australia. We are now recruiting in other parts of the world, and potentially recruiting in Canada and New Zealand and potentially Poland as well. But we haven't yet done that.
Okay. The immigration white paper that has just come out indicates that to qualify for highly skilled work visas, you will have to have an earnings threshold, which is currently around 30,000, and I think your entry for a paramedic is just over that threshold. But if that threshold is changed and is higher, will that present you with?
I think it will present a problem to the whole of the health service. Because on the low, as I understand that, I'm not sure I've got the full understanding, but on lower salaries, people can come in, but they don't have leave to remain and have got to go away again, which would be cause of disruption. And I'm sure all the media coverage we've all seen in the catering industry, care homes, etc. So it would be a problem, I think. But the issue for us is the English universities do not currently have sufficient places for the amount of paramedics we need in this country. And so we need to work with health education and others to make sure that both the paramedic profession is seen as attractive with career opportunities, and at LAS we've done a lot to create opportunities for people so that you don't just come out as a graduate and stay there. What was the career trajectory? What could you do? And for us it should also be about interchangeability with other healthcare workers in the urgent care space. But we need to make sure that the places are commissioned and that universities are encouraged to have more places, because it is a rate limiting factor.
Okay, that's interesting to know. So you'll be making some representations on the immigration white paper, is that right? As that goes through Parliament, that'd be useful. Before I return to recruitment retention, can I ask, is there any other Brexit risks that you've identified? I know Ross Lydell from the Standard talked about you bulk buying ambulances.
That's a good opportunity to correct that, I think.
So there are two things there. Our ambulance stock is very old, and we needed to get on and replace them. And at some point, there may be a decision to have one type of ambulance, but it isn't here yet. And the lead-in time to get the ambulance built is a long time. So it is partially true, and it actually came from me, I think, that the reality is with Brexit, and because ours are Mercedes, we don't want to get stuck with parts not here, so we do need it, but it was more about getting the ambulances fit for purpose and be able to move forward.
Yeah, I think we are locked into a 5-year investment plan to renew our full-size ambulance fleet. We need to do that both because, as Heather says, the fleet we have is quite old and outdated and needs updating, but also because we have agreed a memorandum of understanding with the Mayor around the ultra-low emission zone that gives an exemption from the charges through to October 2023. But that is on the condition of having a compliant fleet by that date, which effectively means that all our ambulances need to be 2015 or newer. So we've just completed the rollout of 140 new ambulances that we ordered at the beginning of last year. We've secured additional funding from the Department of Health to buy a further 30 and put them on the road this year. We will put another 80 on the road next year, another 60 on the road the year after that, and so on through to 2023, so that the whole fleet of about 550 full-size ambulances will be ULEZ compliant.
Okay, so that's a long-term
so it's basically it's a long-term plan.
Yeah. And I know the health service itself is talking about stockpiling drugs in the event of does that affect you?
No, I mean, the Department of Health monitoring whether people are doing that or not. It's less of an issue for us than it would be for a hospital. But we have looked at Brexit as a risk for our risk register and said, we need to look at our external contracts to see. So obviously it remains an issue for everybody, but it isn't as significant for the ambulance service as it is for other health services.
But we will work to Department of Health guidance as and when it's issued.
Thank you. And coming back to the recruitment, and I'm talking about retention now. Yeah. I think in the past, evidence has been it's been the high cost of transport and housing in London that responsible for your high staff turnover. But have you got any other more comprehensive understanding about why in the past you have that staff?
So we have, many of our staff have been with us for many, many years. We have a really stable core workforce, 30 years plus. I gave an award to somebody who'd had 50 years. I mean, it's extraordinary the length of time people do stay with us. It is at the call centre level that we get high turnover, and in some of the support working. And it is true that if you are on a paramedic wage or a lot of our people's salary, you can't live in central London. So housing is an issue. And the other issue is our paramedics have to carry very big bags around. So we are working to have a paramedic bag that is vehicle based, so they don't have to lug it. And the other issue for us used to be that our staff were late off duty, which meant they might be an hour late off duty and then they have an hour to travel home. But we have got much better at getting people off on time. We're sorting out the bag. Housing does remain an issue, and if there's something the Mayor could do on affordable housing, that is clearly something we would be very keen to work on.
Okay, so is there anything you think the Mayor could help with?
I think it's the affordable housing, isn't it, Garrett?
And, I'm not sure it's something that's specific to London Ambulance Service, but yes, you're right to point out that the cost of living in London is a challenge for us, even with London waiting and so on, in terms of attracting and retaining staff. I think there are other things we can do and are doing, though, to retain staff. A lot of the staff that we historically lost, we haven't necessarily lost to London. We've lost to the ambulance services. They've sought to go off and do other jobs to develop their career within the health service. So a big part of what we've been doing has also been around developing career pathways. So we talked earlier about the development of more bespoke services, pioneer services, and developing the skills of our crews to deal with more complex incidents and so on. That's also very beneficial in terms of providing opportunities for clinicians, both registered and non-registered, to develop their careers and so on, and encourage them to stay within the ambulance service. So we're just developing a couple of particular roles that will allow crews to rotate around different skill mixes and so on for a period of time, to help them broaden their career, develop experience, and enable them to stay within the ambulance service rather than having to go off to an urgent care centre to develop their career and we lose them. So I think there's a number of things there.
And the other things would be what we're doing to make it a more attractive place to work, how we support staff who have stressed, a lot of work on mental health, on counselling of how to deal with the angry clients, how you support them. Yeah. So in our call centres, for example, they have beanbag rooms where they can go and just chill out. They have support from somebody working next to them. The occupational health service. There are a whole range of different initiatives that very excellent HR people and OD directors put in place working with staff. And I think if you talk to staff, it was quite interesting to see people who've left and come back say it's a very different place, and they're excited about being there. So we're more encouraged that people actually want to work for us now.
Positive. My final question is around diversity of your staff. I mean, across the trust as a whole, I believe your BME percentage is 13.9%, but that hides a big disparity because on the front line it's only 8.1%, and at your board level it's even less. I believe that only one non-executive director is from a BME heritage background. So can I ask?
It is a major issue for the Trust, and it's one that I and Garrett take very seriously, and we are leading the issue about culture. In terms of, I'll deal with the board and then go to paramedics. You are right. It is, although it is a diverse board in so much as we have women, because diversity is a much wider thing in BME. And so, in fact, there are probably more women on your team than men. Yes, there are, aren't there? But I've recruited 2 female non-execs, and clearly at that time I was looking for people with particular expertise in the digital world and in the people and supporting the people in HR agenda, and we were able to attract very high caliber people for that. I recently I'm not allowed to advertise because we're not a foundation trust, but I put I don't know what you call it, a thing on LinkedIn saying that I was looking for people from diverse backgrounds to join our board. And actually, I've pulled that process because we haven't got the people that we need. So we are actively seeking somebody who can join our board with that background. You're right, we have an associate non-exec director who is from a BME background, and Garrett has a director but not an executive director from a BME background. So it is something we're very mindful of and leading. Garrett and I both sit on either, I think you sit on the national steering group for workforce race equality.
National Res Strategy Group in the health sector, yeah.
And I sit on the London Chairman's group for that, and you meet with the chief execs. It is an issue both in London. To get it right for people from a BME background is difficult, and it has historically been so for LAS, but something to draw your attention to, only 7%, and tell me if I've got this wrong, supporting cast, of paramedics who qualify are from a BME background. And actually our BME background paramedics is exactly 7%. Now, we know that the population from London is 44% people from an ethnic minority, so we are very conscious of the need to address that. Across the organisation, we aim to be at about 20% in 2 years' time, but it's going to be a long journey. What we are working on is making sure that when we do attract people, it is a place they'd want to work.
I think the point about paramedic graduates is quite significant, because in that field we're recruiting from a national pool of graduates to bring paramedics into the organisation, and simply, you know, the national pool of paramedics doesn't reflect the London population. So that is difficult for us. In our control centre, you'll see a very different range of diversity. I think we're about 28% BME, so we're certainly not at the London-wide average, but we're much further forward. And we are moving forward insofar as 2 years ago we were at 11%, we're at just under 14% now. We've got a target to be 15% by the end of this year, and 20% by the end of 2020. So there is a whole range of activity going on. We have a very dynamic race equality scheme action plan that we're just in the process of refreshing and strengthening further to tackle this issue. So yes, I think we both accept that that's a significant issue for us to tackle, both in terms of recruitment and retention, and in terms of workplace experience of those colleagues that we do have from a BME background.
And I think that people from a BME background in the organisation now feel that it is on the agenda for us, and that we are taking it seriously and taking it forward, and they're working with us, and they tell us things are improving. But actually, when you look at the statistics of all the different things that we should look at, it's not telling that story yet.
I think it's also fair to say that this is an ambulance-wide, sector-wide problem. This isn't just a London ambulance service problem.
Okay. I mean, there are a whole host of questions that could come on the back of that. I mean, it's good about your call centre staff, but obviously they are the lower paid.
Yes, they are.
Yep.
End of your staffing. And you talked about trying to make paramedic as a career choice.
Yes.
And working with higher education institutions. Are you working with higher education institutions here in London, which do tend to have, in some respects, some of them are much more broader and diverse?
But still they don't recruit.
Yes, no, we absolutely are. But I think that there is more scope. And your point about the control centre staff and so on is absolutely right. That's why I refer to workplace experience and developing career opportunities. So the opportunity for people in the control centres to either develop their career within control centre or develop their career in terms of moving to frontline ambulance activity, in terms of becoming an emergency ambulance crew person, and the opportunities for emergency ambulance crew people to develop their career by becoming paramedics. So that's the area in particular where we are working more broadly with the system here in London to enable more people from a more diverse background to train to become a paramedic in the future.
And you talked earlier about
is also where we aim, when we've developed our strategy, to attract young people also who might come from a variety of different backgrounds, to see that it's an attractive career choice.
And certainly I know from policing that when the role of a community support officer was introduced, that was much more proportionate to the population as a whole, and then from that those recruits to community police officers went on to become police officers and had quite a dramatic effect. Not as much as it should have done, but they did. And so it seems to me that your volunteering work you're doing with could really target certain groups in that.
Absolutely.
Exactly,
as well.
that's our aim.
Yeah, you wanted to come in, Andrew.
Just on that 7% figure you were going on about, that you're saying that paramedics in general are only 7% of BME.
Yes.
Is that a London figure or national?
That's a national figure.
National.
I don't know. I kind of think that figure's gonna be higher in terms of recruitment in terms of London.
Oh,
Does
it
this
should be,
mean
shouldn't it?
paramedics
But
in
remember,
London
they
are going
don't necessarily
elsewhere?
do their degree in London.
Beg your pardon.
People don't necessarily take their undergraduate training
Right.
at university in London.
Neither do a significant
but
proportion
for
of...
London only to have the national average just seems like underperforming because we are
Absolutely.
more diverse than the rest
No.
of the country.
So, I mean, that's a new
do
statistic.
you see what I mean?
We do,
perhaps I
and
don't
to be
understand.
fair, we'd only just got that number because we were
right.
trying to say what's the, so we need to drill down more. If it's like nursing, it could be that they attract but don't complete. So we don't know, we need to look into it further, but we do know that we need to attract people in London from a BME into other profession. And as Garrett said, starting in the call centre is a way. I met a young man only last week who was at a consultation of the restructuring who had come in. And it was very revealing because he didn't want to be called a call handler because he's not in a food chain. He might be helping somebody deliver a baby. He might be dealing with a mental health case. He would like to be called, something that was more fitting to that name. And I think all these things are important for people to feel valued, to help them go on that journey.
Okay.
Just in terms of that figure, I think that to me the reason why that is significant is because at degree level we're recruiting from much more of a national background, whereas at call centre handlers and in terms of emergency ambulance crew, we're recruiting much more in London, and therefore you should expect that more readily to reflect the population of London, or more quickly. But the goal absolutely is to get up to the point where our organisation as a whole, both in terms of numbers and in terms of seniority, is much more reflective of the population of London as a whole.
And my final question was on that final point you just made about seniority.
Yes.
About, are you looking at your internal processes to see what you can do to make sure there's no unconscious bias and that you're mentoring and sponsoring talented staff?
From the board down, we're involved in mentoring and reverse mentoring schemes. All of our recruitment fairs externally now have somebody from a BME on that process. We've modernised the process so that you can't necessarily tell where somebody comes from. And at a board level, we do have to get better at having more people. But we do challenge those sort of questions. And I think we're looking to learn from other organisations who do better than us, including the Metropolitan Police.
We're also rolling out unconscious bias training to senior employees and recruiters at the moment, and have plans to roll it out to up to about 700 middle managers over the next 12 months or so. All job interview panels, on senior job interview panels at 8A and above in terms of National Health Service grades. We have the diversity manager on, and the aim is to have diverse panels for all of our recruitment as soon as we can. So there is a lot of activity. I'd encourage you to look at our new res action plan when it comes out.
Thank you.
Just whilst we're talking about recruitment and retention, of course, primary care is also recruiting a lot of paramedics, and it's competing with those experts. And there may be opportunities to develop career pathways for your paramedics.
I think that's
too.
absolutely.
That has to be the way
We'd
forward.
very much like to do that.
Yeah, great. What's one thing that the Mayor could do to support the London Ambulance Service? If there's one ask you have of the Mayor, what would that be?
I think
And he's listening.
It is difficult to identify one thing. I mean, I think the Mayor has been incredibly supportive of everything we're doing and has been very willing to lend his voice and his publicity to highlight key issues. I would really encourage him to keep doing that and getting across key messages about how we're evolving the service, picking up the messages that were in your survey around the bits of the service we provide where perhaps Londoners don't have a clear understanding, where they don't see the nature of the see and treat element of the service, and the fact that because you call an ambulance doesn't necessarily mean you're either going to get an ambulance, you might get a different type of care, or indeed that if an ambulance arrives you're not necessarily going to get taken to hospital to have your care, because we have clinicians there that are more than capable of resolving your issue on scene. So I think in terms of getting all of those messages across, in terms of developing an understanding that we are an on-the-road 24/7 service. We're not a service that waits in an ambulance station for your call. We are around the corner when you need us most, but we're continually going from job to job. I think all of those things, to me, I think the Mayor is in a unique position as the leader of political government in London to raise public awareness, and I suppose that extends to some of the other things we've been talking around, campaigns and things like that. I think that they are the most valuable things that the Mayor can do for us.
I think it's telling a story, and it's telling that story about the different pathways, but also the role of paramedics and how that has emerged.
And what would be the main messages you want to get out to Londoners about the London Ambulance Service?
So it wouldn't be about the ambulance service, and that goes back to our strategy, because it is about accessing the right care, the right point of care, which includes the NHS 111, and thinking, it's the appropriateness of calling an ambulance at the right time, and what pathway do you need to take, and we all need to work on that.
And I think, in terms of 111 integrated urgent care, the increasing role we're playing in that, and we'd like to play a bigger role still going forward, because we think we can offer a uniquely high quality service because of the ability to join up not only the call answering element of 999 111, but also the clinical support in terms of clinical hub, in terms of using the capability that we have to manage across London, and also join up with the wider healthcare sector. So I think that's a unique thing that the London Ambulance Service has. We are the only London-wide healthcare provider, so the opportunity to be that focal point for access into the urgent emergency care system, whether it's on the phone or whether it's through dealing with patients on scene, or increasingly, I think, as we get into the digital age, whether it's helping with being able to provide access to services through digital portals, I think is really the future of the service, and I think that's probably the biggest opportunity we have, and that's I suppose how I think that we will go from ultimately talking about having to manage growing demand to actually talking about a system whereby we can meet growing demand.
And I speak on behalf of the Health Committee in that we have found this investigation very, very useful from our point of view, and Londoners have found it very useful, that the opportunity of investigation into the London Ambulance Service, and I think you found the experience also very helpful and getting your message across. Do you think it would be a good idea if you came to the Health Committee on an annual basis to give us an update on the service that the London Ambulance Service is providing?
I think it's very sensible to have an ongoing dialogue, and if once a year did that, we'd be very up for doing that.
Yeah.
Yes.
So we'll make this an annual event at the London Assembly.
Could I
Great.
ask that we think about the timing? Because sometimes, could I
Of
ask
course.
that we think about when's a good time for us to come, so we've got something to tell
I'm
us?
sure the Secretary can arrange that, but I think
Thank you.
that it's very important that
Yes.
Londoners get an opportunity to hear from you on an annual basis, and we get an opportunity to ask
wonderful.
questions which are relevant to Londoners.
But I think it's a good opportunity to track progress on the delivery of our strategy in particular.
Indeed. So thank you very much. Is there anything else you wanted to say before we close the meeting?
No?
No, thank you very much.
Okay, so thank you very much for coming here. Thank you very much for agreeing to come in at least in a year's time, if not before.
Thank you.
So can I thank our guests for the contribution, and finally can I ask the committee to note the report and discussions with the invited guests and delegate authority to me as chair in consultation with the chairman to agree any output from these discussions.
Agreed.
Can we note the response from the Mayor on the committee's report on young onset dementia as attached to Appendix 1 of the report? Thank you. And can I please agree the following recommendations? 1, to agree the proposal of the Health Committee work programme. B, agree to the use of the next meeting on the 27th of November to discuss the Mayor's proposal for social prescribing in London. and delegate authority to the chair in consultation with the deputy chairman to agree any site visit, informal meetings or engagement activities before the committee's next formal meeting. And can we please note that the next meeting of the committee will be on the 27th of November at 10 a.m. Great. Thank you very much.
GLA Chamber